breathing pattern disorders, part 2, stabilization. This is about how your body stabilizes itself, uses the diaphragm as part of that stability system, and how you can look for problems and what you can do about it. Okay, so you're looking at the diaphragm. You got to think about the diaphragm as a piston, right? And so you have your diaphragm sitting here, but in this case, in this piston, there's the piston, and that's the piston. And so when you exhale, there's a relaxation phase. But when that relaxation happens, the fluids within this cylinder become depressurized. The pressure is dropped. But when inhaling happens, the piston comes down, the pressure inside the cylinder is increased, right? That's hydrostatic pressure. That's how heavy machinery works, right? Your backhoes and things are using hydraulics. Your body's the same system, and it works as a hydraulic system. This is a hydrostatic hydraulic system. And so the diaphragm sitting here, relaxation phase, this cavity has a lower pressure, but when that diaphragm comes down, it increases the pressure on this cavity. And the muscles in this cavity that are the container are your transverse abdominis, internal, external obliques, and your pelvic floor, right? That is the container which holds this pressure system together. And when that pressure comes down, what happens is you've got your spine here, the diaphragm sitting here, and your transverse abdominis kind of doing like this. And then when the pressure comes down, you get this increased pressure like this. And then what happens is you get an incredible amount of pressure on your spine going that way. And so what happens is, let me show you again, is inside the diaphragm comes down, you get pressure against your spine this way, pushing your spine from the anterior to posterior direction. And then the transverse abdominis wraps around that because the transverse abdominis connects to your vertebrae and it makes the container, right? And so the transverse abdominis, internal, external oblique, and the pelvic floor are all the container for this pressure system. And the pressure system turns on and off based on your requirements for stabilization. So it'll turn up and you'll get more pressure required if you're picking up 300 pounds, and if you're just bending over picking up a pencil or just walking down the street, you'll just have a little bit of diaphragmatic pressure from the top. Now, I'm talking about this in one, and in the manual therapy, we're talking about this intensely, right? And so if the diaphragm's here and the diaphragm moves down, what's going to happen is all of these organs are going to have to move down too, because everything's connected to everything else. And then these organs on top of the diaphragm here, they have to go up and down as well with the movement of the diaphragm. The diaphragm moves about 4 fingers width, right? That's excursion, right? And so your liver is here moving 60 feet a day. Your kidneys are back here. They move a mile a day up and down. Your guts are a mile a day. And all of that is your lymphatic pump, right? So that's the manual therapy portion, is what are we going to do to maximize the ability for the diaphragm to move through tensions, right? So if there's an adhesion in there, or like the liver is stuck to the stomach, if the liver is stuck to the stomach right here, through this hepatogastric ligament, then the diaphragm can't mobilize through that, right? And so that's the manual therapy portion. This is the exercise portion. We're thinking about exercises now. All right, so what is the postural function of the diaphragm, right? It flattens on inspiration and it lifts on expiration. The expiration phase is a relaxation phase, increases pressure on the internal organs, and that is the pressure system. The volume of the abdominal and thoracic wall expands to accommodate the eccentric isometric load into the musculature. The system exactly meets the demand exerted by the muscle work or the demand of motion. So if you're just walking down the street, you don't need to hold your breath and hold that diaphragm down hard. You just need enough pressure on you to stabilize your hips. So let's go to the next slide and let's explain this. So what you got is you got your ankles here, right? So you got your ankles, and what are your ankles stabilizing to, right? The calf, right? Your calf muscles, right? They're stabilizing your ankle. And what is the calf stabilizing to? Up here, your knee. So you got your hamstring, right? There's an overlap, right? And so this is stabilizing to that. This is stabilizing to this. And then what is this bone stabilizing to? The lumbar spine. And what is this? What is holding the lumbar spine in place? The diaphragmatic container. It's hydrostatic pressure. It is not muscles. The order of stability goes pressure system first, then muscles and fascia, and then your ligaments. And I know ligaments are fascia, right? But once you have the stability system broken, then you start using different muscle strategies to hold yourself up instead of using the pressure system. And that's what we're going to test. It's like, what is the strategy your body's using to hold itself up if the pressure system's broken? Right? And if muscles, they will fail eventually. And once they fail, then you lose the ligaments. And the ligaments, that's your disc, right? The disc of L5, L4. The disc is a ligament. And your L5, the people in the laboratory have done this. They've taken the L5 disc and they put it into a press. And that disc crushed at 90 newtons. 90 newtons is 20 pounds. 90 newtons is 20 pounds. So the stability, the pressure of your body is not supported by the disc, because the disc would rupture immediately because it can only hold 20 pounds. And you're way more than 20 pounds, all the weight of you above L5. So that's not what's holding you up. We want to just kind of track this logically, right? And so let's look at the shoulder real quick. And so the same thing, your hand is stabilizing here. These muscles are stabilizing there. The humerus is stabilizing to the chest cavity. And then what is your pec and the rest of your shoulder and the posterior aspect of your shoulder stabilizing to? They stabilize to the core. And the kind of this X direction where this side stabilizes to that side, but it all goes through the core. And so the core is stabilized by the diaphragm. And so if this here is rock solid and that doesn't budge, then this bone has something solid to hold on to. This has something solid, this has something solid, and that has something solid. And so the test we're going to be doing, we're looking at is how does this respond when we ask you, like your femur, the hip, to stabilize itself? We're going to isolate it out and see, okay, what is it doing? And is this contributing to your pain, right? And so we're looking at global patterns of the body, and we're not isolating muscles with tensegrity anymore. We're looking at the entire system. We're not looking at, well, it is tensegrity, but maybe not the way people are thinking about it. We're not looking at the bicep, tricep, opposites. We're not looking at that. We're not looking at if you have internally rotated shoulders to strengthen the mid-back. We're not doing that because that's really not the problem. And those exercises, they don't long-term solve anything. They're not changing the way your brain is communicating to your body. So now we're going to say we're going to kick a ball. The brain is going to communicate to the core, turn the diaphragm on. The first thing that happens is you stabilize to the level required to kick the ball. And it depends on how hard you're trying to kick it. If you're kicking it as hard as you can, you're going to hold your breath, and that's going to get the diaphragm to come down the hardest and create the most pressure. And then so when this leg lifts up, the psoas is connected in here. The psoas doesn't wiggle the spine around, right? And so 20 milliseconds, and we can measure this. This is measurable. 20 milliseconds before this leg moves, this core turns on. And that's how it's supposed to work. Stabilization and then movement. You cannot move any bone in your body without having a stability component. There's always something stabilizing that. I can't raise my arm in the air unless it's being held on by my rib cage. And what's holding my rib cage in place is my core, right? Because otherwise my thoracic spine will be wiggling all over the place, right? But we're going to see people wiggling all over the place, and these people have specific pain patterns. So let's move on. So that's some really interesting videos in this one. Okay, so that's the postural function of the diaphragm. I think we explained this. Okay, so more on this. And so I talk about a stability component. Look at this guy. He's kicking a ball. And this is a posture that we all know, but we haven't ever really, I mean, if you really picked it apart and thought about it. This is the moving leg. That's the kicking leg. This is the stability leg, right? But what else is stabilizing? Look at the posture. Look at his hands here, and look at this, the action of that. His hand is going out, and that is tightening. His arms are tight, and those are stabilizing this X that I was talking about. So when this leg moves, nothing on top wiggles. There's no wiggle at all in any of this function. It's just the leg coming across, kicking the ball. This is all very solid. And you can see he's stabilizing by just looking at that hand. And you can look at his face. Look at it, the way he's posturing his mouth. He's closing the glottis. He's holding his breath a little bit. And he's going to make a noise when he kicks that ball probably. He's going to go, huh, right? And that's the thing we learned in martial arts. And that noise that you make in martial arts harnesses the core. It turns the core on even more. And so the more you can stabilize your middle, the more power you can generate with the moving part, right? People who are masters at sports, they just do this. They don't need to be coached. And people who are professionals who are getting hurt, you can analyze their movements and you can find flaws in there, and you can actually predict where they're getting hurt. Okay. And so the chronic injuries are not the mobile component. They are in the stabilizing component. And so say a soccer player, he's not going to have pain in the kicking leg chronically. If he has an acute injury, like it just happened, it may be in the mobile component. But usually the chronic pain is the stabilizer. There's something up with the stabilizer. People who have low back pain, their low back is not too stable. It's not stable enough. And I said this before, but I want to say it again. You've got a mobile joint, you've got an immobile joint, you got a mobile joint, an immobile joint, a mobile joint, an immobile, mobile. And so if you just look at it, you got a mobile joint, immobile joint, and a mobile joint. Your body does this and it stacks it like that because you have a moving component and a stabilizing component. The most immobile during motion is hopefully this low back and between the TL junction, thoracic lumbar junction, and S1 into your pelvic floor. That's what should be very still, and that's holding everything together. And that requires diaphragmatic function from above. It's not muscles. And I'm going to prove that. I'm going to prove that just showing you the basic physics of how the body works and how just some basic physics equations. We're going to prove that there's no way that muscles are holding you up. It's obscene. There's no way that's how it's doing it. And so let's see. So breathing influences neuron excitability. What does that mean? It means like when you inhale, that's an excitatory thing. Like your body on the inhalation, your muscles are getting ready to respond, right? And when you exhale, that's a relaxation phase. And so you can see if you're stretching people out. I mean, you know, as a manual therapist, if you're stretching somebody and you get them to inhale and then exhale and you do the stretch on the exhale, you're going to get a much better stretch because the neurons are in a relaxation phase. When you inhale, well, that's the core turning on. Your body's like, what am I doing? Am I going to stabilize? Am I going to make a move? Right? That's all happening on the inhale phase. Exhale is a relaxation phase, right? So it's built into our program. It's built into us, right? And so the diaphragm is controlled by the central nervous system. It is very complex, right? Okay, so a number of studies document the synergy of the diaphragm, transverse abdominis, and the pelvic floor, and the multifidus during postural activities. These things turn on. There's an order. And so what we're looking at is what order does your brain tell your body in which to fire? Is the core coming on first, or is it like your glute turning on to stabilize the opposite hip and these other strategies that the body will come up with? If you lose that diaphragm function, you're not just going to fall apart. What you're going to have to do is what's going to happen is you're going to break slowly over time, right? And that's what we're trying to avoid. And as exercise specialists, this is where we're going to shine right here. And this really fixes some problems. Now I'm going to show you some videos. Now this is a ballroom dancer. And we can guess where his pain's at. So I say, okay, get in your position. So let's go. So that's his position. With his shirt on, he looks really good, right? And from the front, where he practiced in front of a mirror, he's very good. He looks good. He's in the position. But what is he actually doing? And what he's doing is causing himself some pain. What he's got here is a scoliosis that he's created. Yeah, that's his position, creating a scoliosis. Where's his pain? X is a pain. Pain, pain, pain. So what's going on? His trap is overactive. That trap's pulling on the occiput. He's getting pain there. He's obviously pinching off right here. And he's holding this for like 8 hours a day, right? And so you're going to break. If you want to be competitive or move into like that level of dance, you have to be totally stable and relaxed. And so this is him with his shirt off. And so what we did was we coached him out of this position, and he already had some stability coaching. I've worked with him before on this, but okay, so we're going to say, okay, let's fix this. And so we coached him out of that, and we said, okay, this is your new position. Excuse me. Okay, and let's watch it again. Okay, so I'm going to talk through it. So here's his new position. And so what is he doing here? What's the difference? And so what he did was, and you could still see the overactivity right here. You can see that overactivity, but that's neurological, and that's going to calm down in time. So what he did was, first things first, you're going to start with a core activation. Right? Not too hard, soft, but enough to activate. And there's 18 muscles that stabilize your shoulder. And the shoulder should work like a kite. There is no muscle that's over tight, right? And so your scapula is sitting here like this. You've got your rhomboids coming in this way, your serratus anterior this way. You've got low trap going this way, and that low trap's going to end up into the lat and end up into the thoracolumbar fascia, and that energy is going to end up here into that glute from that shoulder, right? But look, so it's like, okay, as he externally rotates that hand up, he's going to actually rotate that. He's going to activate serratus anterior, and that's going to start getting this to relax. When you just turn this bone just a little bit, and then he spread his body out this way like a kite. And so he's getting that spread. And then all the pain is going to be gone when he holds this position, because his spine is now straight. He's got rid of the scoliosis. Now, what I did was, it's a habitual thing. So it took some work. I put some tape, and I just kind of taped his serratus anterior, like kind of tape his scapula down to remind him, hey, hold that. And then we put some tape to just externally rotate that. And while he was dancing, and he was really sore for the first week, and then this became neurologically imprinted into his brain, and this became the new dance position, and the pain went away. Now this fellow can dance the rest of his life, and he's not going to have these pain patterns, and he's not going to develop injuries. And honestly, when he put his shirt on, the wrinkles out of his shirt smoothed out. And then his dancing went it really, really improved actually, and his movement really improved, and he was softer and he was calmer through his movements because he wasn't flexing. He wasn't flexing. Look at this flexing he's doing. It's coming up and ouch. Like try to do that for 8 hours. It's like, oh, how about just calm it down and get symmetry across your muscles? And doesn't that look better? So that's what we're talking about. That's how we're helping people. There's no exercise, one exercise like a using bands or something going to do that. Now, I wanted to show this because I've been sitting on these videos for like 7 years on how are we using acupuncture to map the body. And so you've got the anatomy trains, and I like anatomy trains, but they're not always exactly right on because you are a moving, living being. You're living and breathing in time and space. And so you're not a cadaver on a table, right? And so we're using needles to act as gauges. And in this case, this is a time trial cyclist that I talked about actually in the other video with the very predictable issue. So we're watching that needle that I circled, okay? And let's see what happens. Okay, we're watching that needle. Let's see what happens. Now that's the tissue is moving. That needle, he doesn't know that that's moving. That tissue is moving back and forth. That's what's moving the needle, the fascia underneath. And I'm just rotating a rib up top. I'm literally just turning a rib. And you can see just how connected. That's the very slightest movement of a rib up top. And it's moving that fascia that much. He can't feel that. He has no idea. And I'm turning a rib. Now, you could imagine, I hope you're trying to get like how you can get lateral knee pain if, say, something is unstable throughout the system, because this really matters, right? And what I did with this fella is I worked that system until that needle stopped moving. Then I know that I disconnected that fascial system right there. And I don't know what fascial system that is, honestly. I'm moving a rib, and it's kind of unpredictable, actually. It kind of follows anatomy trains, but loosely. I like anatomy trains, honestly. And so here's one, and this lady's a runner, right? And that's lateral leg. It was lateral leg day so I just took videos. And it's the same, moving the rib. And it could be from the left side, it could be from the right side. This one's on the same side. Sometimes it's crossbody. Okay, so this lady's pretty unstable, and she's running. So here's the needle, and I'm up here, and I'm just moving this leg back and forth. Now, what am I doing is I'm actually rotating her pelvis, right? I'm moving her pelvis. And that's the lifting of the pelvis. So that's the pelvis affecting lateral leg. And then this is the same lady. And so turning her rib was affecting lateral leg. And I'm turning the rib, I'm just like slightly rotating it, right? And so she's got some instabilities going on here. And so that's her pain point, right? And we all have people with pain there. But there's no rubbing of this in the IT band. That's not going to get it. You can roll your IT band out all day. It's still going to hurt. Okay. And then we're getting more detailed. Watch that needle right there. And I can literally turn that needle counterclockwise and clockwise based on the direction of which I'm taking that fascia on her back. Now, I'm not turning the rib here. I'm just using fascia. I'm just like, she's just rotating like the superficial fascia, moving her skin, basically. And she's just talking and having a conversation. She has no idea that that's spinning in there, right? The needle is not in there digging, reminding. It's the tissue that's moving the needle, okay? They're awesome gauges to tell you what's going on. So here's another one. Wait. Okay. So this guy had wrist pain, okay? And I'm pushing the fascia here, and this is the needle we're looking at, this one in the wrist above the thumb. This guy is so tight. Rock climber. And when I push the tissue down, the needle goes up. So what's going on is an unloading of the fascia, the deep fascia. And the deep fascia is going this way, right? I'm pushing this way, and the whole thing's so interconnected and so tight that the whole thing moves this way. And that's what's moving the needle this way. You see that the base of the needle is what's turning? The base of the needle's like this. The base of the needle's doing that. And so this was going that way, right? And then so we'll break it down further. Grace. Now I'm like, okay, let's get more specific with this guy. Same guy. Okay, and I'm like, okay, let's just get right into the septum here. I'm just going to move the ulnar nerve. I'm trying to move just the ulnar nerve here. Now, this top needle, that's skin. Don't worry about that one. This is the one we're looking at. Just lifting the ulnar nerve. Now, does the ulnar nerve even go there? No, it doesn't go there. And so what is going on here, right? I'm grabbing the ulnar nerve. I'm lifting ulnar nerve. It should be on this side, but it's so fascially stuck, it's going to his pain point. And so this is the difference between looking at a cadaver and knowing where nerves go and actually just looking at the body and go, okay, this is a living being in time and space. What is going on in this system, right? And so you poke around and I found this. Now, this guy's not stable. This is compensating patterns of his shoulders, right? This is all rooted deeper into his shoulder. And of course, it's going to go to the core, right? These are really strong individuals who have breathing pattern disorders and are not stable, okay? So I'm showing you this. Okay, so here's one. So I'm slipping the rhomboid. If you don't know this, you need to know this. The rhomboid and serratus anterior are the same muscle. They hit the medial border of the scapula and they change names. So this is really important. You've got rhomboid, then you got your scapula, and then it keeps going down and it hits serratus anterior. It's the same thing, right? It's kind of like the upper lower trap. I really wish they wouldn't have changed the name because it causes a lot of confusion and derails people. Okay, so we're looking at this needle here. That's like in the tricep area though, and I'm just pushing rhomboid here, and this is one of the lines, one of the arm lines. And so when he crosses his body, can you imagine how much more pull is on this as he tightens the rhomboid serratus area and he tightens this area here. So if he reaches this way and this gets tight this way, his elbow is going to be cranked on even more, right? These are compensating patterns that I'm pointing out here. That shouldn't happen, but it happens all the time. And so what I'll do is I'll just work that until that needle stops moving and I know that I release the fascia. If you say, well, I don't have needles, that's fine. You can put your hands on one spot and put your hands on the other and you can feel this stuff. That's how I did it for a long time, is I'm trying to feel each section of the fascia, like have one hand on the leg and one on the upper body and see what's going on. And just play with that. You're going to find all kinds of connections. Okay, so enough needles. This is just straight abduction of the shoulder. And so this guy's pain, well, I'll just play the video. You can see where it hurts. We can raise your arm up. He's like, boom. That's trap dominance. That's trap dominance, as max trap dominance as you can get. Right there. So, ouch. Terrible, terrible pain on the galea right there. This is where the trap attaches in. His trap's crazy tight. And what's going on here is when he begins the arm movement, his trap fires. So his trap is leading the way. And so he has trained his trap to hold the weight of his shoulder. So when that motion comes up, his arm is literally hanging off his neck. And the muscles are starting to get tight and weak. And so they're pulling on the periosteum right here and just cranking on his head, and it's giving him headaches, right? And it's just every time he moves, right? Or watch it one more time. And this is a rehab, a stability rehab. There's no exercise like isolated muscle exercise going to fix this. We have to change the way his brain is communicating to his core, and then add arm movement. We got to change the stability component from his shoulder down to the core. He's got to get external rotation in this. He's got to be able to turn this like that, get the serratus anterior on, and we're going to put him in positions that's going to get that trap to turn off. And I'm going to actually show you a video of that. And unfortunately, these guys, once they're better, they don't come back. So I don't have a video of him doing this, and it doesn't go because he's fixed. Okay, so ouch. Okay, here's a woman who had low back pain, and she said, well, I was doing bird dogs and I hurt. And so what you have to do with these patients is go, okay, show me your exercise. I want you to do the exercise and show it to me. And so this is what she did.
Okay, go ahead.
And we're watching this section. Not too bad, unstable, but not bad. That's bad. Kink. So let's watch it again. It's like, well, yeah, your back hurts. And she's doing hundreds of these things for her low back pain. There it is, this kinking. And she's rotating and kinking. She can't stabilize that motion whatsoever. So if she watched the TL junction, she's kind of good there, not that great. But this rotating, now she's totally falling apart here. And so let's look at her back. So I'm like, okay, let's look at what's actually going on. So this is her spine. And so this is the erector spinae right here. Those are the erector spinae, and they are just firing. All she's doing is sitting there on hands and knees. They are just on and cranking on her back, right? And these muscles are not strong enough to hold her. That's why they just turn into bricks. So let's watch as she does the exercise. There it goes. And so her psoas is fighting the erector spinae. She has no inter-abdominal pressure holding her spine in place. And so they're just fighting for their lives here. And when you see these grooves, that depth, that is not right. Her low back should be smooth, right? That's her spine going anterior, like it's retreating anteriorly. There's not enough to hold it up, right? And the angles of these muscles, there's no way they don't have the advantage to hold it up. You would have to have, something up here that goes to the spine to hold it up. You need this vector to pull it posterior, right? These paraspinals run this way, and the angles are not, they're not steep enough. They need to be this way to actually be functional. These are not holding you up. It's the pressure from underneath that's pushing it. It's an incredible amount of pressure, like 1,200 pounds of force going on your spine with proper core stability. That's what's holding you up. I'm going to show you some physics on that. So, ouch. When you see that, you know that it hurts. Okay, so we're looking here. This is a hip flexion test. So his arms are not touching the table. And we're asking him just raise a leg. So he's going to come here. He's going to raise a leg. So just raise that like an inch off the table. And then we're going to look at what this is doing. And we're looking at what his belly button's doing. The belly button will tell you what the spine is doing. If the belly button is shifting left or right, if this is shifting left or right, he's giving himself a scoliosis. So let's see what he's doing. See the curve, the curvature? When he's raising this up, he's getting a curve like this. And from the posterior aspect, which I'm going to show you next on somebody else, what you're going to see is a scoliosis happening. And this is happening all the time. And so his spine is literally shifting. And then he is digging this leg into the table to try to desperately stabilize because it's floating in the air. And he's trying to find something to hold on to because he doesn't have the stability system. This is low back pain. Let's watch it again. Let's go.
Hit the other side.
You can see pockets appearing where he doesn't have stability right here where this mouse is. And he's going too fast for this exercise, but it's the only video I had, so I like somebody slower. But you guys just see he's curving off into space here. And this isn't even a bad test. I have never, ever had an L5 disc herniation that wasn't positive on this test. They are all positive, 100%. And they literally like almost fallen down on the table. They can't even come close to doing this. They're not. This guy's really good, actually. Okay, so here's a ballet dancer doing the exact same test for the posterior aspect. You can tell she's already curving, sitting here. She's in pain. She's like a serious dancer, like hours and hours a day, going to New York, dancing like big time. But she's found a muscle stability system to compensate so she looks good. You can't tell unless you isolate her and you break it down like this.
Okay, so raise the left.
So she's going to raise left leg.
Okay.
And see the shift of her spine up here. She's shifting over here, trying to find something to hold on to because I took away all of her stability components and I'm leaving it to the core. So this here should never move. You should not even know she's moving. It should be soft and still. That's how this works in actual stable person. And that's her lifting the right leg.
Okay, so raise the left.
She can't do it.
And then put it down and do the right.
And this is somebody who's
Okay.
Professional level ballet dancer, right? She's in a lot of pain, which is part of ballet, I guess, because
Okay, so raise.
she thinks it's no. Okay, so here's a guy hurting. Okay, so this guy's pain pattern is here. It's a TL junction pain. He's got pain here. He's got pain here, like that. And we're like, okay, take your shirt off and let's see what's going on. We're just wanted to see what is your stability strategy when you move that may be contributing to this pain.
Okay.
So I just think about raising your head. That's the cue. He's thinking about raising his head, barely lifting it off the towel, and he's turning into the Incredible Hulk. Like look at the paraspinals. Look at these, all these mid-back collection, all the pain. This all hurts. This section here really hurts on him. He's trying to relax. He's doing the best he can to be relaxed and be stable and just lift his head off that. All of this is involuntary. This flexing, he's not planning that. Okay. This is why we need to neurologically exercise them. We got to go, okay, we have to get this pattern to let go. If this is happening just by holding your head up, you have no hope of not being in pain. You will be suffering. Look at the groove here. And look at the pull on his sacrum. We talk about SI joint pain. Okay. This guy is suffering and he just needs exercises. You're not going to fix this with manual therapy. You can't rub this out and make it better. It's not going to work. He needs neurological repatterning of his stability system. And that's what we're going to talk about in class. Okay, so here's a guy who used to be like the first guy, but he got a rotator cuff surgery and he got his long head chopped and removed off, and they moved it down. But he can't raise his arm, and so we're doing these exercises for our post-op rehab. And so, and he's getting a flat, and it's just like the ballroom dancer. He's learned how to turn this off.
And elbows go towards your pubic bone.
He's got nice activation. This is all smoothed out. And watch what we're going to do. We're going to make him rotate his head.
Palms are flat. Right?
He's going to rotate his head, and now he's rotating his head. And you cannot rotate your head and have a tight trap at the same time. See, we're doing a brain trick here. We're neurologically shutting his traps down. Where as the first guy with the abduction and his trap was firing, this is what fixed him. This exercise right here, it stopped doing that. It totally stopped doing that. And this is clean, and this guy could raise his arm after this. And he's doing PT as well, right? Because he's post-op. We don't do the post-op PT. We're doing this stuff. This stuff is
And elbows go
really
towards
good.
your pubic bone.
It's very clean. He's straight. He's got the alignment of his spine. His core is on,
And the palms are flat.
and now he's going to rotate. So now the traps have to let go. They have to let go. That's a big success right there.
There you go.
He's lost his rotator cuff though,
Shoulders.
and so we're bringing him back in, and he's not all falling apart yet. So that's good. He was just like the first guy. And here's a kid. So I wanted to put in a video of somebody who's not trained, and this is just how you're supposed to move as a baby. This is a 2-year-old. Obsessed with climbing ladders. He would do this without you watching him. So, and look at the smoothness of his spine. He's not scoliosing. He's got the 18 muscles. They're all symmetrical. It's very smooth. His core is on. Look at the little belly. It just blows out, then it's relaxed. It turns on and it turns off. It's very smooth, his back, as he moves through this. You see, he's shrugged there, but he's moving. He's actually moving in position, and it's supposed to do that. You're not a robot.
Full confidence.
There's absolutely no stress on the system. He's using only the muscles that he wants to, that he's got. But look at the hip flexion. Let's take it and look at his hips. He's got no roll, and so look, what we want is a straight head, respiratory diaphragm to the pelvic diaphragm in a straight line, and everything's aligned. And then, so when he gets hip flexion, this is true hip flexion. There's no rounding of the low back. If you see the low back rounding like this, then that's going to be pain, and that's extra strain on the low back. So we want that rounding gone. And so it's about like, how can you get hip flexion and a straight spine? And that's full mobility, right? And so he's totally stable. There's no rounding. Even he's struggling there, but that's it. There's no rounding of his low back. He keeps the alignment the entire time through this whole movement. And that's how it's supposed to be. And he's moving. He's making adjustments. He's totally stable.
Oh,
Attention.
dude, what you got? Full confidence.
There we go. So
We did it.
So that's stability. And hopefully, if he doesn't do a lot of sitting or a lot of computer or a lot of like looking at his phone as he grows up, he will maintain this. This is how a human being is supposed to be. Okay, let's go on. So sling angles. You're like, what the hell are you telling me about sling angles for? Well, because your muscles are slings. Okay. And the angle of which they're attached makes a big difference on how strong they are and how much weight they can hold. Okay. And so this is really important. Okay. So now I say this is a 2,000-pound load. So, and the sling angle here is 90 degrees. So we're talking about this right there. So this is a basket hitch on this load. So you've got here and here. And so each side is holding 1,000 pounds. There's 1,000 pounds of force on each one of those slings. Now, as you change this angle, now I change it to 60 degrees. Now the amount of force on this sling right here, what that sling feels is 1,155 pounds, right? Now, if that sling has like a max capacity, or how much, whether its breaking point of like 1,000 pounds, you've exceeded the capacity of that, right? And as I change this angle to 45 degrees, it's 1,400 pounds. And if I bring it to 30 degrees here, Now, this right there, that sling feels 2,000 pounds. The weight, this load here is 2,000 pounds, but this angle creates a tension on it, and it has 2,000 pounds of force per side. And so if your capacity was, say, 1,200 pounds, you have now broke your sling and you're going to have an accident. And so anybody doing crane rigging and people do lifting, they know this. If you're setting rock climbing anchors, you should know this. They don't all know this. I've seen some really bad anchors. Now I'm going to take this angle. I'm going to go to 15 degrees. What is the force on the sling at 15 degrees? 3,800 pounds. And if I go even tighter, like to a 7 degree, now it's 8,000 pounds of force on that, right? We've way exceeded the capacity of this sling by bringing the angle in, okay? So why in the world am I telling you this? Well, your erector spinae, let's have a look at your erector spinae. So what is the angle of your erector spinae, and are they holding up your back? Because you've got vertebrae 1 and vertebrae 2, and then you got these transverse processes sticking out, and the angle of these guys are pretty darn steep as they go down, right? And so if you look at sling angle and how much force you're asking your back to hold, it's very unlikely that these guys are holding anything at all. And that's why they're turning into bricks when you ask them to work, right? They don't have the mechanical advantage to do that kind of job. The pressure, the back needs to be supported from the inside out. It's being pushed. It's being pushed by the diaphragm this way, holding it this way, right? That's how that works. It's not your erector spinae. In doing just bird dog exercises, it may help in a temporary way, but maybe like that other lady, you're creating another dysfunction because you're not actually fixing the problem. You've got a breathing pattern disorder. You need to stabilize the core, and then you have to bring your hips and your shoulders into that stability system, because these poor paraspinal muscles, they have no hope of doing that job. And if you've been in this career field long enough, they don't work. It just is not going to work. Okay, but here's the third class lever. So this gets even worse, right? And so what I'm looking at is the back, right? The back is the lever. So you've got your back here. You're picking up 40 pounds of trash. You got your 40-pound bag of trash. Your legs are here, and you're trying to go this way, and you are creating now a third-class lever, which is not an efficient way to do this, the way that we're doing it. And so what you got 40 pounds. If you're 20 inches from the source, say that's 20 inches, that's about right. And so the head's here. And then it's like the fulcrum, it's about 2 inches, because it's like you're at L5, S1 is that fulcrum level where the pelvis and the hip is. But if you're not stable, it's definitely in the low back, right? And you're trying to come up. So how much force is on the low back? How much force is on the low back? It feels like 400 pounds. So that 40 pounds, when you bend over and pick it up, it feels like 400. It's like 400 on your L5. And how much weight can your L5 hold in a press? 20 pounds. So if you don't have something going on, and are your erector spinae able to hold 400 pounds at the angle of which they're at? Maybe not, right? That's why you have to bend the knees, and we do all this stuff for lifting. But if you're stable, you can actually bend over and pick stuff up, because hydrostatic pressure creates like 1,300 pounds of force, depending how big you are. The diaphragm creates like 1,300 pounds of force. You're way more than 400. But that's a static system. And we're not static, we're dynamic, which means we're always changing, right? We're living forms in time and space. We are this, a moving system. And so you have to use this equation. And momentum equals mass times velocity. P equals mv, right? So this is momentum is P, mass times velocity. Okay, momentum is the force of which the core will have to hold, right? It has to absorb momentum. Now, if you have like a semi truck going 55 miles an hour and it hits a wall, that wall has to absorb the momentum of the mass of the semi truck times 55 miles an hour. It's a lot of momentum. It will destroy the wall, right? And the truck. But we have done experiments in very high speed guns where we have something like the weight of a quarter, right? Just a coin, right? The mass is the weight of a coin, but the velocity is 7 kilometers a second, which is really fast, right? 7 kilometers a second. And so velocity is so high, the momentum equals the same as that semi truck going 55 miles an hour because of the speed of that quarter. And whatever that quarter hits gets absolutely disintegrated, right? And that's just the way physics works. Now you've got this bridge, and I've got a better picture of it. I could just use this. So you've got this bridge. Now this bridge has got some serious mass, right? This is a serious mass, like this thing, heavy. But I guarantee you that's very deep and a lot of concrete, right? There's tons and tons and tons of weight to overcome this thing. And it's not, you still have the lever, right? Because it's a class 3 lever, right? Because this is your fulcrum and there's not much going on past that fulcrum. So I'd say it's class 3. And so, but it's moving. So it's going like this. And the speed of which it's moving adds to the pressure on this system here. This system has to overcome and stabilize the speed of the movement. And so this bridge is not going to be moving fast. No matter how much or what motors you put on there and you want it to move fast, if it moved fast, this entire thing would collapse and break, right? And it's the same thing with the human body. If you add speed to it, you can get more of an injury. If you're stronger, you can get more of an injury. Okay, so the equations go way up. And so if I add this to your 40-pound bag of trash, and now you're twisting and throwing the trash into the dumpster, you could easily get, depending on the size of the person, you can get 1,500 pounds of force on L5. Right? And what did we say the diaphragm? The diaphragm creates 50 psi. So you calculate the amount of surface area of the diaphragm in inches and you times it by 50 and you're going to get like 1,400 pounds, right? And so that 40 pounds of trash that you're moving fast and throwing, which I don't recommend, is counterbalanced by that 50 pounds of psi of the diaphragm coming down. And this is the only way that the math works out for your body. It has to be the diaphragmatic hydrostatic pressure that holds you up, right? Because you're a moving system. Okay, so here's a big baseball player, and he's going to hit the ball. And so there's some components going on here, right? Core stability. There's going to be a breath hold or when he hits the ball because he's really trying to nail it, right? The weight of the bat, his mass, the mass of his body, the mass here, and the speed of which he can swing the bat, right? Now, if he's swinging the bat fast, say he's swinging it fast, and the core isn't stable and it's wiggling, then his arm is going to be wiggling and his hip's going to be wiggling, and he's not going to contact the ball exactly, and the bat's going to be wiggling, and he's not going to transfer all of this force into the ball. You want as much stability in this bat going into that ball, so the only thing that's moving is the ball. There's no other wiggle, right? It's the bat just literally goes right through the ball, right? And then the ball goes, home run. So that's how that works. You have to have this, but it starts with that core. So ontogenesis, I'm going to talk a little bit about this. I cut out a lot of ontogenesis because I want this to be an introduction, and we can go on and on about development of babies. The more you understand about how the baby develops, the more you understand about your own stability system, because it's still going that way, right? We didn't decide to do something different as adults, right? We're using the same stability system. And when we do the exercises, you bring the adult through the same motions as which the baby was going through. And so you're taking advantage of infant reflexes. You're taking advantage of these infant reflexes. And so I'm not going to get too much into this. But, in utero, like the neurological abilities of the baby is just based on just survival. What comes online, lungs, liver, guts, heart's working, the brain and the central nervous system is developing. But what the important thing we want to show you is it develops from the middle outward. Okay. And so everything close gets developed first. And this kid, when they're newborns, they don't have control of their extremities. They're just kind of flopping around, right? They can't control their extremities. The reason why is the CNS, the central nervous system, has not developed there yet. It's only developed this far. And then as they grow throughout the first year of life, they get more and more control. Now, and the thing that leads the way in control is the diaphragm. So once the diaphragm starts working, they get sphincter control. They can now stabilize their core. Their low back is stable. And now when they raise their leg has something to hold on to. It has to hold on to something to move. There has to be a stability component. And so now when that leg goes up, it can stabilize to that core. And there's a whole process to this that I'm not going to get into because it's a lot. But we're going to show you some of these infant reflex points in class and be able to take advantage of this stuff. Because for an example, the palm, when that palm hits the floor right there's an infant reflex for that shoulder to start stabilizing to come online. When that shoulder comes online, the core starts coming online like that. Right? And so we could push on these points, and there's a memory inside you that just brings this stuff out. Right? We're going to take advantage of that. And so post-uterine, I just said, it goes from the inside out. That's all I'm gonna talk about there. Okay, diaphragmatic origins. We need to cover this though. Okay, so you've got a costal origin and you've got a crural fiber origin. So the crural fiber is here, and that's the legs of the diaphragm. Crural means legs, right? The talus crural joint, that's your ankle, right? Crural means legs. And so there's multiple origins of the diaphragm. And there's a hole here, right here, this hole. Oops, that hole right there. That's where your esophagus goes through, right? Your esophagus drops down, and you've got the lower esophagus, because your stomach is right here. You got the lower esophageal sphincter about 1/2 inch under the diaphragm. And the diaphragm is part of that sphincter's function, right? Because the lower esophageal sphincter is a weak sphincter, and it's weak so you can vomit. And you can't vomit without a diaphragm, right? Because what happens when you vomit, I'm getting off track, but I'm going to tell you this anyway. So what happens when you vomit is this portion has to relax to let go of that lower esophageal sphincter, and then this portion will contract and turn inward and squeeze the stomach to cause the vomiting. It's your diaphragm that makes you vomit, right? And when you're a baby, you don't have sphincters function because your diaphragm doesn't work until you're 6 months old. That's why before 6 months, they're spitting up randomly, right? And after 6 months, they'll still puke on you, but we all know that, but not as much. Okay, so CNS is really important. So a CNS dysfunction disease is like cerebral palsy, right? And this process that we're going to show a little bit of, that we're not going like the DNS is dynamic neuromuscular stability. It's out of Prague. We are not trying to compete with those people. Like they're taking it all the way. We are giving you the introduction to breathing pattern disorders and basic stability, right? I would really, really encourage you to take the dynamic neuromuscular stability classes from the guys in Prague. We're not going there, right? They're doing such a good job. There's no need for us to try to repeat that. Right? It's pointless. They're awesome. And so I've taken their classes. I'm certified through them. I'm going to one. You know, every year I go to one or two. They're great classes. So we're not trying to replicate them. But where this came from is a fellow named Wojta, who was during the Cold War. He was in Eastern Europe, and he was a loudmouth, and he was a political issue. He was causing political problems because he couldn't keep his mouth shut. But he was a neuroscientist and a pediatric. I think he was a pediatric MD. Don't quote me on that one though. But he understood children and he understood ontogenesis very well. And so they didn't want to kill him because he was a genius. And so they stuck him up in the mountains, like just put this guy in the mountains, and they gave him a bunch of cerebral palsy kids. They just shipped them all to the mountains and put them away. And so he's got nothing else to do there. And so he's watching these cerebral palsy children, and he's like, okay, I know how they were supposed to be developing, and they're skipping normal steps in the ontogenesis step. Like they didn't crawl properly. They didn't go to standing properly, right? Because they're cerebral palsy. Their central nervous system, it takes a lot for the central nervous system to coordinate all these functions, right? And so what he did was he's like, okay, I'm going to make you crawl. I'm going to use these infant reflex points. I'm going to push on these spots, and I'm going to see if I can get your hips to become more stable and see if I can get you walking better. And he did an amazing job with these kids, right? He really did a great job rehabbing these kids. And then he taught other people. His work is hard to find in English, but there was Janda and Luvwit, and then Kolaj came along, and he's the guy running it now in Prague. And so Kolaj took it into sports. And he was an Olympic athlete himself. And so he took a group of Olympic athletes and he put them through this exercise process. And the one that the DNS uses, we're just going to intro it. And so he put them through this process, and then an intensive weekend. And on Monday, every one of those athletes got a personal best at whatever sport they were in. It didn't teach their sport. What he taught them was like how to get the power to your legs, how to get the power to the javelin, right? And so he got rid of all the wiggle, right? So all those equations that we showed you before, all of that force was going into like the foot when they're running. There was no wiggle of their spine, right? He made their bodies work better. Okay, so this is cerebral palsy hip angle. And I'm showing you this because we have to respect anatomy. And these kids develop in a wheelchair, right? And they can walk some, but they're not walkers. And they skipped all the developmental stages, right? And so they're coxa valga. What that means is this guy's hip angle, and this is a child. This is a young child. You can tell there's two things, right? Right here, the ramus of the pelvis is not sealed yet. But that may be because it's cerebral palsy, right? Because he didn't have the forces on the pelvis to actually create, because this should be one piece right here, right? And then you can see the growth plate's wide open still. But that angle, that's coxa valga angle, means this person's going to have narrow hips. And they're going to have narrow hips, and they're not going to gait like a normal person. They're not going to be able to squat like a normal person. They're going to be handicapped in a way of this motion for the rest of their life. And so if you're working with these people, trying to rehab them and work with them, you got to respect their anatomy. They're not built. They're not built like a typical hip. They have different structures. Now, there's more to this. There's a thing called anteverted and retroverted, right? And so you've got the ball and socket joint. Now, if you're retroverted, you're sitting in your shoulder. The way your shoulder sits, the acetabulum is retroverted, it's facing backwards. And so if you're retroverted, you're going to be able to put your arm back farther than somebody who's antiverted. And so if you're retroverted, your arm's going to be able to go back farther because the way the ball and socket is aligned, you're going to be a good baseball pitcher. If you're antiverted, you're not going to be able to throw a ball. You'll be a good presser. You can bench press and things like that. But an antiverted person, you're not going to be good at the rings in gymnastics because you can't get your arms back far enough, right? You're not going to be good at a lot of gymnastic things because you don't have that mobility backwards, right? The same thing with the hip angle. If you're antiverted, the hip angle, you're going to be able to kick a ball, like a soccer player, or crossbody, right? But you're not going to be able to go to first position in ballet. You're not going to have a turnout, right? But if you're retroverted hip, you'll have a great turnout, but you're not going to be able to kick a soccer ball, right? Not across your body. And so if you have somebody, and we all have these different angles of our hips, and I know in Russia, at least in some countries in China, they're X-raying people, kids, and they're picking their sport according to their hip angles and what they look like. And that makes a whole lot of sense in taking a kid who can't put his arm back and making him a baseball pitcher, and he tears his rotator cuff by high school, right? And so there's a thing about respecting the anatomy of the person in front of you, right? Whether even if they're cerebral palsy, you have to respect these narrow hips and just set the bar according to their actual physiological abilities. Like, some Caucasian people will never have a great straight squat. They can go down, but their legs, they have to have a turnout, right? Because you have to respect the hip angle. Okay. So we'll talk more about that in class during the exercises. Okay, so alignment of the thorax. We're almost done here with just this intro. And so here's a baby. This baby's probably like at least 9 months and probably a year. So you've got an alignment of the pelvic floor, the respiratory diaphragm, and the oral fascial diaphragm. And I think there's 5 diaphragms. The other 2 are up in your head. And then so this kid's aligned as a younger baby. And this guy's getting into a deadlift position, and he is aligned. And so that alignment, that diaphragm has a straight, that's not straight. Diaphragm has a straight shot into the pelvis. And so the pelvic floor can stabilize. Now, when you're breathing, it does this. Your pelvic floor is relaxation space. It's moving up and down. But when that diaphragm comes down to stabilize, the pelvic floor comes up, right, to meet that. If that doesn't happen, then you have leakage and whatnot. If your respiratory diaphragm is not aligned with this oral fascial diaphragm, you will not get the excursion that you need to get the pressure all the way into the pelvis. If the pelvis is stable, to stabilize the pelvis, you've got to get that pressure all the way to the base of the pelvis, which means all the organs need to move. All the organs need to move into the pelvis that are there, right, as much as you can. And you need to create hydrostatic pressure into the pelvic bowl. This kid here, you can see, if you're paying attention, if you have a baby, it's ideal because you can just hold the baby up and then tip them a little bit and feel what happens to their belly. The diaphragm, it comes on. So there's an eccentric load of the diaphragm this way, right? And just tip them, give them a little off balance, and you can feel that load just turning on and off. Okay. And this is an introduction. Don't worry if you're not understanding it completely. We're going to go over it. Okay, so the central nervous system of the diaphragm, I left this on here. And this is like more detail than this class is going to go over. But the diaphragm is innervated by the vagus nerve and the phrenic, right? The phrenic is the voluntary motions of the diaphragm, and the vagus is the involuntary part. Now, I'm using my phrenic nerve to talk. My diaphragm is actually creating, the suction and the noise of the sound. It's like constantly doing. That's a phrenic nerve doing that. Apes, chimpanzees, they don't have a phrenic nerve to do that, right? That's why they can't talk. They'll never talk because they don't have that voluntary control of the diaphragm like we do. And so one of the things you can do to hack into the vagus responses, the vagal responses you're having, like you're having stress, is you have this whole involuntary systems that are going off. Say you're having a panic attack, right? And so the heart rate's going up, the breathing's going up, and all this is happening. And so what you can do is, because the diaphragm is voluntary and involuntary, you can voluntarily control your diaphragm and slow that breath down by doing some kind of conscious breathing activity. And because you're consciously controlling the diaphragm, you can hack into, like a computer worm, you can hack into all the other systems and start getting control of those. Okay. And so you can calm the system by using the phrenic nerve. Okay. And I think the phrenic nerve is very, very underestimated in the problems it's caused. The phrenic nerve, it innervates the skin of the liver. And so if your liver is irritated, your phrenic is going to be irritated. You're going to have pain here. You're going to have pain right there. And it's just very underestimated in the problems that can be created for it, especially C4 neck pain. If it's C4 neck pain, think about phrenic nerve, right? And it just travels here. And the subclavius is innervated by the phrenic nerve. So you could use subclavian tone of the subclavius muscle to tell what the phrenic is doing, right? That's a great piece of information. Basically, I poke on subclavius and I go, does that hurt? And they're like, yes, phrenic nerve. And I just work the phrenic and I use the subclavius. You go back to subclavius and you just push on it right there and you go, okay, is that better, worse, the same? And it should be getting better as you're working the phrenic, right? A lot of C4 issues are phrenic nerve, actually. Okay, adaptive capacity, and then we're done. Okay, so adaptive capacity, what is that? That is your body's ability to adapt for the activity that you're asking, the stability you're asking, the movement you're asking. The capacity is where it can no longer adapt anymore. So you've exceeded your capacity. That's your adaptive capacity. So as you're stabilizing, your body has to choose to breathe or stabilize. Like if you're lifting heavy weight, it's going to have to make a choice, right? You're going to have to limit your breath in some way to stabilize if you're doing heavy lifting. And your body will always choose oxygen over stability because stability causes a chronic long-term problem. Oxygen loss causes death today, right now. Your body is not going to do that. It's going to choose the long-term issue, right? So you will drop your stability system right out from under you and everything will just start going to heck. And so let's look at some athletes beyond their capacities. So this guy's reached his adaptive capacity and he's way beyond. So this fellow, what's going on here? So you can see he's lost control of the glottis. He can no longer use the glottis to hold the interabdominal pressure. He's trying to hold it in his cheeks, right? So he's completely broken and cracking. He's got this internally rotated, so his shoulders are starting to fall apart too. This is probably like rep 150 or something. His shoulders are starting to fall apart. He's getting internal rotation of this shoulder. He's starting to hike this. This elbow is starting to bend to keep the bar straight as possible. So he's bending the elbow because this is more powerful than this. This is internally rotating. And I'm going to make some predictions here, and they're probably going to be right because I worked on a lot of CrossFit people. So you look at his core, the stability here, how it's starting to hollow out. He doesn't have that pressure on the inside. That should be smooth. He's getting a diastasis. His abdominals are splitting. His rectus is turning on here. And as that rectus abdominis turns on, it's smashing into the transverse abdominis and the internal external oblique. And those things are supposed to be soft and opening like this, right? Now, if you've been pregnant and you had a baby and you have this diastasis, this abdominal splitting, there's a technique to close that during the stability component. That's not what's happening here. This guy's beyond his adaptive capacity. He's breaking himself. But it's a competition, and this is part of his sport. Okay, and so here's what I'm predicting is going to happen to this guy. He's got lumbar scoliosis, does he? Well, let's see. Is this straight? No, it's curved. So he's getting a curve to the left. See his belly button? It's the hip flexion test. The belly button's beginning to shift. He's lost the glottis control. He's upper trap dominant with an imbalance right to left. Look at this trap compared to that trap, right? And so what's going on is this is coming up. There's a raise of that trap because that one's firing. And then now he's got to bend this elbow to compensate. And so that bend of that elbow, that is very heavily stressing the bicep. And so this is going to be a prediction here. I'm just making a guess. He's going to blow his bicep tendon out right there. I mean, he's going to have a bicep injury because you don't want to do heavy weights with your bicep on these lifts, right? You want your arms to be like cords hanging, and then you use the momentum and then snap it up using the back, not your biceps. And so he's straining his biceps, because this is out of level right here. Because he's beyond his capacity. Maybe he's got diastasis, maybe he doesn't. Internal rotation of the humerus on the left more than the right. Look at his pecs. So his pecs are overpowering the serratus anterior. Get rid of that. Okay. So he's firing this like crazy, and these guys are dropping in, and they're going into internal rotation, and he's rolling his back. You see how his back is like curving? It's doing this, right? He's lost the serratus anterior rhomboid combination, right? It's just folding in on himself. And if you freeze frame these guys on their 150th rep, you can predict their injuries. Okay, so he's going to have a shoulder injury. He's going to have a bicep injury. It's going to be rotator cuff. It's going to be here. It's going to be that guy. That's going to go. And he's probably going to maybe have a hip issue, because if his spine is slipping this way, what's probably happening is his adductors turning on and this opposite glute to try to pull it back, right? Because they're going to try to pull that back. And so there could be a low back issue here too as well. But he looks cool. Okay, so let's look at this woman and see what she's doing. And now that we know that this diaphragm should be aligned with that diaphragm, should be aligned with this diaphragm, we know for a fact she is not stable during this motion, right? Because these two would be aligned, but they're not. They're off. And so what's going on is she's lost the stability to push her spine this way. And she's using mass times velocity of her legs to create momentum on her low back. So now her L5 has to stabilize this swinging motion. So she's doing kipping pull-ups, right? And this is, the same thing, probably 150 in. But this is almost worse, because she's going to get an injury right here at L5S1, because what she could be doing here is, if she was stabilizing this section and that was actually turning hard, she could actually be bouncing on that. She could learn how to operate her core in a way where when she swings her legs back, the momentum goes into the core, and then the core is not going to move. It's going to not move. And then that will bounce her back this way. So if you could teach this athlete to stabilize properly, you see how her head is forward? If you could teach this athlete how to stabilize properly, she'll actually be more efficient on the bar, right? And you have to sell it to these people like you're going to be able to do more reps, right? And get them clean, and then teach them about adaptive capacity. And you never exceed your adaptive capacity, especially when you're practicing. If you watch the world CrossFit athletes, they do not go beyond their capacity. They do not exceed it. They never come out of position, ever, right? And that's how they're at that elite level. They're not hurt. They never exceed their adaptive capacity. They don't go that far. And they're world champions. So she's going to get what I would guess a spondylolisthesis, which we talked about in the last one. is where this pars break. So every time she does a swing, this bone here, this one, it's stressed. She's banging that bone, boom, boom, boom. And so that can only take so much, and then it's going to snap or slip. There's going to be a problem. And so this is a potential of that kind of injury. It may not go during the event or during her exercise. It may be years later, because she strained it so much. And if she's not stable on the bar, there's a really good chance that she's not stable anywhere else, right? And so you would take that athlete, you put them in the hip flexion test, just like the people like the ballet dancer, and have them do that in front of a mirror and let them watch their body and see, this is how you move in space and time, right? We're not cadavers laying on a table. We have to respect the living matrix inside and how the brain communicates to that. Your brain is in charge of absolutely everything. The order of how your muscles fire, how they stabilize, that's all your brain doing that. Your brain does that. Okay, so if your diaphragm isn't contracting and flattening down equally, there's going to be an instability, right? And that's predictable. And we're going to learn how to test that. We're going to learn how to test the diaphragm. We're going to learn how to flatten the diaphragm and get that. That's the goal of this class. That's a big deal for somebody. Patients with low back pain on dynamic MRI machines. This is an MRI machine where you're moving. They had greater flattening of the lumbar portion, the crural portion of the diaphragm, as compared to the healthy population. So if you had back pain, your crural portion was dominant. And we can look at that, just say, what are your paraspinals doing? If your paraspinals look like you're smuggling 2 baguettes from France in there, your crural portion is overactive. And the goal is to get that nice and smooth, get all the organs above and below moving. And actually the educating of the patient is the most valuable thing. And putting them in front of a mirror and showing them how they're dysfunctional. That's the most important part. Identifying improper stabilization. Well, here is a telltale sign. This is what I'm talking about. It's just an overactive paraspinal. Now, what is this? That is a cupping mark from the person he saw before he came to our clinic, and that didn't work, right? There's no cupping. There's no manual therapy. There's nothing you can do to that spot to make that better. He needs neurological exercises. You can't push on it. Nothing's going to work. You need to change the way his brain is communicating to his core, because he's using these muscles, which I hope that you understand now, have no chance of holding him up. He's using those muscles to hold himself up. And they have no chance of surviving. It will break. It will break. That's what all that math was about, which I didn't go into the math, but you can if you want. So an abnormal stabilization function always goes hand in hand with the breathing pattern disorder. If your diaphragm doesn't work, you can't stabilize, and you end up into these people, like those people at the adaptive capacity, that guy doing the cleans, his diaphragm quit working for his stability system, and then all that stuff broke loose, right? And that's what happens. Okay, so I think that's that. And so that's stability. If you have questions, put them in the comments. I think I'll get a hit on that. And I can answer it there, or email, or whatever, or save them for class. This is pretty exciting. This class is a big deal, man. This little bit of information goes a long way in helping people. If you're an exercise specialist, I would take this stuff very seriously and go to the next level. I'm only introducing this. Our breathing pattern disorder stability, it's like 7 hours of lecture, right? And I reduced it like to 1 here, right? This goes far. And then we're not going to come close to talking about what the level of what the DNS and the Prague guys teach, and they come to America and take their classes, right? And just let's get some people better. Let's help some people here.